can review this meeting at a later date for informational purposes only. So you have arrived to the Bergen-Passaic TGA Ryan White HIV/AIDS Program Part A Subrecipient meeting. Today is Wednesday, February the 8th, 2023. A quick overview of what today's agenda may entail. We'll do quick introductions and welcome. We'll talk about, since we had the State of the Union last night, we'll have the State of the TGA. Millie will give us an update on what's happening in the TGA. And then we'll look at some technical assistance review for early intervention services. We'll talk about the tiered case management program, and then we'll turn it over to eCompass and RDE for the new platform rollout and some new features that are coming to eCompass very soon. We are scheduled for 2 hours today, and people are going to continue joining us. So we will keep this as brief as possible and give you back as much time as possible. I do not see us going the entire 2 hours. However, we are not against that as either. And so well, that's not where it's supposed to jump to. It's supposed to jump to welcome to introduction. So, Miss Karen.
Yeah, I'm sorry. Rollout, is it just me or is it everybody?
Say it one more time.
Breaking up a lot. And I'm asking, is it just me? We're having issues with our phone and computers today.
Oh, okay. Yes, I think it's you. If anybody else can confirm, because you are breaking up. But again, Ms.
Okay.
Yes, we are breaking up to the second lines.
Okay. Can you all hear me okay?
Yes.
All right, perfect. So we will record this. So if anybody has any questions about it later and needs to re-review it, we will make that available for everyone. All right, so really quickly, with the welcome and introduction, since we do have a pretty large group with us today, I'm pleasantly surprised that everybody was able to make it. So thank you again for joining us. If you will just simply drop your name, organization, and your position or title at your organization in the chat, that will help us later on capture. Again, we also know those of you who joined us because you had to pre-register to get the link. So again, we appreciate you working with us in that aspect as well. And with no further ado, we will turn it over to Millie for the State of the TGA and any updates that she may have for the Ryan White Part A program. Millie?
Yes, I have quite a few, but I'm not going to give them all. I'm not sharing all of it. I do want to say that we did get the partial award. I did share that with Derek on Tuesday, so he could give you that information as I was going for a medical appointment. We got 26% under the Part A and 16% under MAI, which was a very small amount of dollars, though, which should be okay. That's the way they broke it. But at the end of the day, the funds that we should be okay within the amount of dollars that we basically get on a yearly basis. So I don't think there's any worries to the amount that we just got. I think it's just based on how behind we are on providing them with the unobligated balances and the updates as far as the drawdowns and things like that. That's more of recipients throughout the TGA and AMA, not necessarily the amount that, I don't think it's going to affect the amount of the funds to that extent. I do have concerns based for all subrecipients, and I'm glad everyone is on the call. I need reallocation of funds. This is not happening. I've been requesting this since November. And as of today, I think I received 2 or 3 at the max requests for that. Based on your expenditures, you should be able to know if by the end of this month, you're gonna exhaust those funds. And I'm happy to say, on the other hand, that we're basically almost caught up with all the reimbursements for December. So we're really missing January and February. So I honestly want to say to everyone, you need to take a look at the expenditures and put in your reallocations of funds, because again, as I mentioned before, I'm going to have to go in and make that decision myself. And I don't think I should be the one to do that. I think it should be on the subrecipient side. We have a new staff, part-timer. His name is Phil Velasquez, and he has the senior program monitor position. Phil, you want to say hi?
Hi, everybody. Very happy to be here and happy to join the team and very willing to do as much as I can. And I'm here for you guys if you need me.
Welcome aboard, Phil.
Thank you.
On the other hand, we have updates with RDE, and they're gonna work with us, and we're gonna take eCampus to another level. So we're gonna need all the assistance from everybody, as you know, as much as they can. I think those were the most pressing items. I'm gonna turn it back to you, Thomas.
All right, thank you, Millie. Any questions from the audience?
Of course.
No,
There he
Jerry,
is.
you're not allowed, Jerry.
Drum roll.
Bad boy, Jerry.
Just a point of clarification.
Mhm.
On the reallocation request, so you're talking about a forecast on what may be unexpended or what you may need to move from one category to another. Is that accurate? You're not looking for an actual budget mod or amendment?
Correct, yeah.
Okay,
It's a reallocation, not the mod.
okay, thank you. Simple today for now.
You're so good.
That's one of two, Mr. Jerry. I'm keeping track today. All right, any additional questions for the recipient's office? All right, let's see. We'll try to share again. All right. So moving right on, one thing that I did want to talk about today during the provider meeting is early intervention services, and do a quick training and answer some questions about what does early intervention services mean? What does it look like? And so we'll start off really quickly with looking at what HRSA-HAB and the Ryan White HIV/AIDS program national monitoring standards say for the Part A program. So when we think about what the performance measures are and what methodology that HRSA-HAB requires EIS to be delivered in, we have to keep in mind that Part A funds cannot be used for HIV testing when there are other federal, state, and local programs existing in the jurisdiction, okay? There are some instances where the recipient can go and ask for special permission, but more than likely, if there's other federal programs in the area, it's going to be a hard no. Also, we have to make sure that when providing early intervention services, we need to make sure that we are working with local agencies who do provide HIV testing and prevention, and making sure that we have some type of what we call a memorandum of understanding or a memorandum of agreement or some kind of linkage agreement with these organizations if we're not doing the testing ourselves, to make sure that we are able to get people who test positive referred and linked to healthcare and support services, okay? So if that's an internal process for you, that still has to be documented in the client's chart of saying, Thomas tested so-and-so positive, and now I turn it over to Derek as the supportive case manager or EIS worker, however you may be funded. Some additional components of early intervention services is making sure that health education and literacy training are provided, and literacy training in the sense of how to understand their diagnosis and how to navigate services, which will ultimately enable clients to navigate the system of care better. Also, EIS should be provided, again, in coordination with key points of entry, meaning those places where people may test positive. Again, that's where the MOU or MOAs come into effect. Also, a coordinated approach at working with our local, state, and federal jurisdictional HIV prevention efforts and programs. So if you remember in December, you probably heard a lot of talk about the integrated HIV prevention and care plan being worked on by the state. The local jurisdiction, the Bergen Passaic TGA, worked in alignment with them in creating this program. So here you kind of see that same effect taking a place in the EIS program as well. Always keep in mind that the targethiv.org is one of your best friends. It is the technical assistance component to HRSA HAB. So if you have questions or looking for a program or some type of service model, Target HIV does have those links for you, and you can also find the national monitoring standards there. So when we talk specifically about what the subrecipient's responsibility is in providing, excuse me, in providing early intervention services, these are the things that you will see out of the last monitoring visit that you some of these look very familiar, right? So these are the things that we were looking for as a baseline to make sure that certain programs were taking place. And we already know that a lot of these things are not in place. However, hopefully that was an eye opener to say, if we're providing certain services, we need to make sure we're at least meeting the minimum threshold. And that minimum threshold is what HRSA says has to be done. And for EIS specifically, on the administrative side or programmatic side, meaning behind the scenes and not direct services to clients, we need to make sure, again, that there's an established MOU or MOA with key points of entry into care to facilitate access to care for people who test positive, right? If you don't have MOUs, that will be a finding, right? And those findings will be taken into consideration when organizations apply for funding in subsequent years. So a continuation of being non-compliant with certain services does give the recipient the threshold to withhold those funds or not fund you in subsequent years. Document provision of all 4 EIS components, right? So, and we'll talk about the 4 EIS components in a second, but making sure that
Bryce. Oh, Bryce.
oh, somebody's not on mute.
Am I supposed to answer the front when it rings?
Eric, can you mute them for us, please?
Sandra,
Okay.
mute yourself, Sandra.
I got her. Thank you, Tisa. All right. Also making sure that we're documenting those 4 components required by EIS. And again, we'll talk about that in a second. Document and report on the number of HIV tests and positives if your organization is doing that with other funding, right? HRSA wants to know what type of prevention programs you're working with and how many HIV tests you've been doing, as well as when and where those funding testing sites occurred. So if you were out in the community doing testing, et cetera, with your prevention funding, state funding, or other federal funding, and you have EIS, you are required to report those numbers. Document HIV testing activities and methods that meet the CDC, Centers for Disease Control and Prevention, and or your state requirements. Document the number of referrals for healthcare and supportive services. Document referrals from key points of entry to your EIS program. Document training and educational sessions designed to help individuals navigate and understand the system of care. Establish linkage agreements with testing sites where Part A is not funding testing. So again, it could be you internally with state or federal prevention fundings. And to make sure that those referrals to access care, education, and again, navigate the system of care. And finally, obtain written approval from the recipient to provide EIS and points of entry that are not included in your scope of work. So for instance, you decide you want to find a new point of entry, then you can reach out and do some new MOUs. All of the Public Health Services Act citations and the HRSA HAB policy clarification notices where these particular items come from. So your citation sources are here. Any questions about that? And so really quickly, I kind of want to roll into what does this look like when we talk about monitoring, okay? And I created 3 particular instances here with 3 unique clients. So this is how we will assist the recipient's office in monitoring early intervention services. So we will start out, and all of these things should be documented in your client's file. And this may change. This is the baseline. Millie may add some additional things to this, or some additional items may be added as subsequent years take place. But this is the bare minimum that HRSA is requiring. First will be for you to document the date of enrollment. And as you see here for our test 1 is a newly diagnosed client. We will be looking at what type of clients come in because each one of the clients will have a very unique process in the monitoring section, right? So what type of client are they newly diagnosed? someone who was lost to care, or someone who was returned to care, okay? Was the client tested for HIV for the newly diagnosed? The answer had been yes, and their HIV test result came back positive. There is the option here for negative, and to ensure that people who test negative are immediately disenrolled or discharged from EIS services. Once you find out the client is negative, Ryan White services through early intervention is no longer an option, right? Ryan White services are for people who are HIV positive or affected by HIV. All right, next. So for this particular instance, the person is positive, so these questions will be not applicable, and therefore you did not have any results for that person in the negative sense. Next, we would be asking, was the client enrolled into medical case management services within 30 days, right? So here we will find out the answer is yes, and the date of the referral will be calculated from the date of enrollment, right? And so you will need to document how that referral process took place, and then automatically it tells us that was within 26 days. Is there going to be a penalty if somebody gets the 31, 45? Probably not. Overall, it's just an ability for us to be able to track it and give a statistical analysis to say, on average, it took this amount of time for people to get from enrolled to that particular referral. You are highly encouraged to please stay within the compliance guidelines. So if this is 30 days, try to meet that 30-day guideline, right? Next, was the client referred to outpatient ambulatory health services within 30 days? Again, I made these numbers up. For instance, the referral for outpatient ambulatory took place on 6/13. The client's first medical appointment date, which you will need to track because the whole goal of EIS is getting people linked to care, took place on 7/22, and we'll see it took 43 days for the outpatient referral and 82 days for the client to get into care, right? When we start looking at additional projects in coming years, for instance, with data to care and things of that nature, these numbers will be hugely significant when we also start looking at ending the HIV epidemic. Next, we'll look at the referral to health education risk reduction within 30 days. Again, these are the key components that HRSA requires us to do. So again, this client happened to be referred to HERR, excuse me, within 26 days. And then finally, when was this client discharged? And probably people are asking, like, what? You discharge people from EIS? Certainly do, because you've already linked that client to medical care. Millie will be working on some guidelines with the subrecipients onto how to establish that. Probably the first year, the typical request is to, move people along after 6 months if it's someone who's not being compliant or adherent to treatment, and you're having to continuously look for them because they keep becoming lost to care, meaning that they're not going to care, then we will encourage you to continue them in EIS. All right. So that was kind of a newly diagnosed client. Next, we're looking at someone who's been lost to care. Lost to care means that they were in care at once upon a time, and all of a sudden they just up and went missing. Mr. Jerry, yes, sir. You're on, sir.
All right, so I'm attempting to just get clear again. So looking at this test 1 client and looking at number 4 in particular, if the client was not tested or received a negative HIV test result, was the client discharged from EIS? Does that mean they were enrolled in EIS and they were billed? What does that mean?
So that's correct. They would have been enrolled in EIS.
Okay, and this is where I'm not trying to be difficult. I'm trying to get clear on this. So my original understanding is that a client is not eligible for a Ryan White service unless they are positive.
Yes, sir.
However, if
Nope,
you're
you're correct.
enrolling them, you don't know if they're positive or not until they get a test done.
Sure. Yes, sir. And so I think there are some instances that we saw during monitoring where somebody received a preliminary positive. And so they were immediately enrolled into EIS to make sure that they had a blood confirmatory test. And so in that case, people are eligible with a preliminary positive. It was an OraQuick or something of that nature, and you need to get that Western blot, or
Mhm.
confirmatory. So in that case, the answer is yes. Very, very few instances where those are false negatives. But there were a case or two where somebody had a prelim positive, or the organization never received a testing confirmation from the point of entry, so they had to repeat the test, if that makes sense.
Okay, thank you.
Yes, sir, you're welcome. Great question, though. All right, so the next one again is lost to care, and that means someone who was previously in care or known to have been in care, and no longer in care. So this particular instance would be maybe your medical case manager says, hey, Derek's hasn't returned my phone calls. We've been looking for him for 6 months, and we haven't been successful in finding him. And you need, a little help from your early intervention specialist to get people re-engaged and linked to care. Again, so you already know the client is HIV positive, so there would not be a need for an HIV test. We would just simply annotate that as return to care. 4 would be not applicable because we already know that they were a previous client and they had been lost. And again, this doesn't have to be one of your clients. This could be from a medical provider you have an MOU with. At XYZ hospital, they call and say, hey, here's a list of 5 patients we haven't been able to get in contact with, right? So EIS can do that as well. And then we start that whole process again. For this particular client, I use for instance, that you could not as well contact that client, right? So the client was given to you for what I call, it just left my mind. Case finding, there we go. I call a case finding, where the client was linked. You had one of your MOUs reach out to you to say, I can't find them. Can you help us? And then you spend approximately, and Millie needs to define this as well, 90 days is my suggestion on trying to find that client before you disenroll them. So here you'll see that a lot of these things are not applicable simply because we're not able to make contact with that client. An allowable cost, however, not someone that you keep on your roster for 2 years because you're hoping they may call you back. That's not an acceptable form or method of charging. So you make a telephone call, once a month for the next 2 years, that's not acceptable. So Millie will have to define a threshold on how long that process takes. The next one is someone who's returned to care, and this could be a couple of different instances. This could be.
I just have a question. So are you saying you can bill for EIS even though you don't make contact with the client?
If it's case finding, if you already know that client's positive, if you have an MOU with an organization that says, hey, Paula, this client hasn't been to medical care in 2 or 3 months. We can't make contact with them. Can you help us? So yes, and then Millie will put a threshold on how long that can take place.
Okay, thank you.
You're welcome. Excuse me. The next one is the return to care, and this could be a couple of different things. This person could be someone who has moved into the jurisdiction that's new to the system of care and just establishing care, right? And so to ensure that the client is able to navigate successfully the new jurisdiction and the new services, you can enroll them also into EIS, right? And in this case, it could also be someone who started out as a loss to care, but you found them and now you got them re-enrolled in things. Does that make sense? So this could be kind of 2 things. The loss to care would be someone we never were able to make contact with, and that's going to kind of X everything out. And the return to care would be someone who could come lost back into care, or someone who moves new into the jurisdiction, right? Or, just someone who's been falling out of care for a very long time and they came back. And so again, we would just annotate those in that particular method and then calculate all of those days for the thresholds. And that's a really quick, brief overview of early intervention services as we start moving throughout the year. I know this is kind of new for everyone with some of the changes that took place. If we need additional technical assistance where we need to have a meeting with EIS providers, please let Millie know, and Millie can coordinate some additional technical assistance trainings. And then as the thresholds begin to be identified and defined by the recipient's office, those will be instituted as well. Any questions about EIS? All right, perfect. Oh, well, that was my next slide. This is where I was going to type if anybody had any suggestions of how we could make this better and more well-defined, or more per se a standard operating procedure of sorts. We do, Millie does want to leave that up to subrecipients to determine how they want to provide these services and in what aspect. And so we don't want to be too prescriptive, but also we want to have some basic baseline requirements for compliance to make sure we are hitting all the key points that's required by the federal legislation.
So my question or thought would be, in terms of EIS being new for some folks who were doing outreach, what type of information is expected to be collected? Like what type of enrollment or intake are you looking at?
That's a great question. And so keep in mind, enrollment would be the same as establishing eligibility for a client in the Ryan White program, right? So it's eligibility information. Are you going to be able to get eligibility information for those who have lost a care, and you may have a referral from someone to say, hey, I can't find Thomas, can you help me find them? No, you're just going to have to kind of pull that information forward out of the eCompass system and utilize, their last contact or their last medical visit, using that information. So we do understand that wouldn't technically be an enrollment per se, and that we would kind of waive the threshold for having to complete eligibility, but nonetheless, that process, some type of enrollment process should take place.
So just have a question. If a client tests positive, say in Bergen County, and they get referred to us, but they're from out of county, can we at least provide like 1 or 2 services just to link them to their county under EIS?
They would have to have they would have to reside in, they would have to follow the, unfortunately, the eligibility policy. They would have to reside in either Bergen or Passaic County. You could provide services, but you could not charge it to Ryan White if they don't live within the jurisdiction. Does that make sense?
Yeah.
Millie may have some leniency there. That would be a question that we would have to ask the project officer. So if Paula, if that happens to be an instance that happens often, then that may be something that you want to submit to Millie, and then Millie can go to the project officer to ask for permission.
Okay.
You're welcome. All right, any other questions about EIS? Was this helpful a little, I hope? No, maybe not.
My question is still on the table though. So again, relevant to monitoring, you're just going to look at, so there needs to be some documentation that the client was referred to medical case management, outpatient ambulatory care, and was referred to health education risk reduction. Is that a progress note? Is it a form? Does it matter?
It does not matter at this point. Just that if we can, as monitoring comes to look at things, that we can find documentation of these items. And so let me also say that you do not necessarily need to refer the client out to a health education or risk reduction funded service if that is something that you are providing, as part of your medical case management service or case management services, then that would count as compliance. You would just need to document that the client had received health education and risk reduction counseling during your case management visit, etc. Does that make sense?
Yep.
Okay. Check the chat. Yes, we will definitely share the PowerPoint. Somebody asked in the chat if we would share the PowerPoint. We would definitely do that. Yes. All right, any additional questions, suggestions? Again, we do recognize this as a change, so this year, I will say, for lack of better terms, will be kind of a pilot year for us to go out and look and see how things are going, and for subrecipients to kind of shoot Millie, technical assistance requests and suggestions, what's working, what's not working, so we can kind of revamp and regroup. And Jerry, maybe your suggestion is exactly what you're saying is there a particular form that we would require everybody to complete to kind of check the boxes? So maybe that is something that, after a couple of months or after the first year of EIS, if we reconvene and kind of discuss and see how that's working out for everyone.
Thomas, I have probably a little over a dozen clients that when we started doing EIS, we were supposed to discharge them after 2 medical visits, which sometimes happens within 30 days. So when we run the dashboard, it comes up that I have like a dozen or so clients that are not retained in care, when really they are. It's just that I closed them because they're no longer, we did short-term EIS.
And okay, so what for those particular clients, are they referred to Ryan White providers?
Some, not all.
Okay, and I think that's where kind of we may be running into that issue. Because if they were referred, not saying that you have to, because they have a choice. If they were referred to a Ryan White provider for Part A, then that data would automatically update and say, hey, here are their medical visits. Again, another data component that we understand is kind of broken, that we really can't fix, because we can't bring every provider in the area under the Ryan White program. But keep letting us know, Paula, so we can work with RDE and trying to figure out how we can fix that.
Okay.
Yes, ma'am. You're not, by no way, shape, or form will you be penalized for anything. It's just statistical analysis.
Okay, thanks.
You're welcome. All right, so let's kind of move on to the next topic, which would be the revamping or a new roadmap to case management service delivery model. And this is something you probably heard me talk about a couple of times, of really asking ourselves the hard question of, does the service that we're providing help to end the HIV epidemic? And if we look at Policy Clarification Notice 1602, we do recognize that non-medical case management services does not allow you to track, or it's an unallowable expense to track medical outcomes, because that is not what non-medical case management does. So in response to that, I had suggested to the recipient's office that we start taking a look at possibly collapsing non-medical case management into medical case management. And before anybody gets excited or upset, like, oh no, we're going to lose non-medical case management funding, or we're going to lose staff. That's not the intention. The intention is just to roll that in the case management. Those people become medical case managers. And then we look at a tier system of delivery, okay? So case management is one of the most essential tools in a lot of Ryan White jurisdictions to help with service delivery to ensure people with HIV can navigate and obtain core medical and support services. Redesigning the case management system in the TGA will allow people with HIV to successfully navigate the service delivery system and ultimately achieve and maintain viral load suppression and assist in ending the HIV epidemic. The development of a newly designed acuity scale will assist case managers in the identification of service needs for our consumers, and the scale will acknowledge strengths and resiliencies and help empower people with HIV to overcome obstacles in their life and link them to appropriate services. So when we think about ensuring parity across our service delivery area, so when we look at case management, excuse me, during our most recent monitoring visit, we did recognize that case management does not look the same. People are not operating case management the same. And in many cases, they are not even meeting the minimum threshold of what HRSA requires in case management services. And so when we look at what are the required components for someone who is enrolled in medical case management services, these are the required components: initial assessment of service needs and an acuity scale, develop a comprehensive individualized care plan, the coordination of services required to implement that plan. And so things that Millie and I saw as we looked through the monitoring were cookie cutter care plans, right? So I had the same care plan that Jerry had, that Paula had, that Derek had. It was just a copy and paste for every client. I was not spending specific time with the client to get to know what their needs are, and that's not acceptable. We're not doing that client any justice and trying to identify and address the needs of the client, right? We are just cookie cuttering it and getting them out and charging our FTEs. So that's not an acceptable form of case management. Is that happening everywhere? No, there are some shining stars who I could ask about a particular client and the case manager could roll off their entire history for the last 7 years, right? And that is the intention of getting our case management system up to par and parity across the entire service delivery area. And so that's why some adjustments to the case management system are needed. Continuing on, continuous client monitoring to assess the efficacy of the plan. So that means once I write the plan, I got to check up on that plan, right? What happened that Thomas needed a bus pass, or he didn't have transportation, or he had a medical nutritional need? What did I do to address that? And so that means that you actually have results of the care plan, right? So I gave Thomas a bus pass to go to his outpatient ambulatory visit, and then follow-up note that says Thomas attended his outpatient ambulatory visit and is virally suppressed, or things of that nature, right? And that's what we're not seeing. We're not seeing well-written notes for case management or follow-up of plans or reevaluation of plans. Again, simple copy overs and pastes and put back into the file. We also want to ensure that there's a client-centered service that links clients to the necessary healthcare needs, psychosocial needs, and other support services to help assist clients in accessing private and public programs for which they may be eligible. So you probably heard it numerous times. Ryan White is the payer of last resort, not most convenient. So if that means that you have to spend time today because Thomas may be eligible for Medicaid, that is something we want to see. So, you know, with some new processes coming in our health information system, we will be able to run statistical reports to say, who are the people who are eligible for Medicaid in our system and why aren't they there? So we'll be able to run those reports to say, okay, you have 40 clients who are eligible for Medicaid, but nobody's ever applied for the Medicaid application, right? Again, so holding our case managers accountable for the actions that they need to take in order to make our clients successfully navigate the system. Next is coordination and follow-up of medical treatments, ongoing assessment of clients and other family needs, whether that be in their personal support systems, again, treatment adherence and client-specific advocacy. So one thing you may have heard me say is a revamp of the acuity scale or acuity tool. So we really got to take a better look at that and to see how we can create an acuity score or scale or tool that will align with the new 3-tier case management system. The tool will be utilized by case managers or the eligible staff in that service category to assess a client's acuity level. It will review various life areas that impact a client's ability to remain in care in order to achieve and maintain viral load suppression. While administering the scale, case managers and the staff are encouraged to listen and acknowledge the client's strengths and resiliencies, right? It's important to listen to clients and hear where they are. This helps to empower clients to overcome obstacles in their life. Systems of oppression impact people differently based on their identities, and additional intersecting identities can create higher burdens and or levels of resiliency. So it's important to make sure we're meeting clients where they are and understanding who they are and what impacts their care. Any questions so far?
Thomas, TC here from Capco.
Hey,
But aren't we doing that when we do our cars or when we do our service coordination plan? Aren't we already doing that piece?
So that piece is there, Ms. Tisa? Yes, ma'am. I agree. And again, not everybody's doing them.
Okay.
So that's why we kind of want to do it. This will be an educational series throughout the entire year for case management. And it's going to be a process that we will ask people funded for medical case management to join in on and to give input, because we want to build this as a system that we all agree upon that all case
Right.
managers are going to be doing these actions.
Okay.
We don't want it to be siloed. Does that make sense?
Yes, it does. It does. Thank you.
You're welcome. Mr. Jerry?
Yeah, you heard me, huh?
I saw you come off mute.
Yes. I want to go, and maybe I'm missing something. Can we, I'm trying to get the original premise that you started with relevant to why not non-medical case management.
Sure.
And
So
I think that was your first slide or two where you relevant to this section here.
Yep. So this is where we started. So I think my initial comment was that non-medical case management will not get us to ending the HIV epidemic. And as a matter of fact, you're not even allowed, it's not an allowable expense for you to charge for tracking medical indicators. So if we have clients who are in non-medical case management, are we essentially tracking their health outcomes, right? And the answer to that is going to be no.
Okay, so therein lies my issue right there. Okay, so I took an opportunity to look at a couple of different things relevant to this. So I'm looking at the National Monitoring Standards for Non-Medical Case Management as a starting point, which is PCN Clarification Notice 1602. And it talks about performance measures, method, documentation. So under non-medical case management, it says the scope of activity includes guidance and assistance to clients obtaining medical, social, community, legal, financial, and other needed services. So relevant to non-medical case management, there is a direct correlation and connection to medical care. Let me go further. Looking at PCN 1602. Non-medical case management, I'm reading directly from the document from HRSA's website. Non-medical case management services, description. Non-medical case management services is the provision of a range of client-centered activities focused on improving access to and retention in needed core medical and support services. Non-MCM provides coordination, guidance, and assistance in accessing medical, social, community, legal, financial, employment, vocational, and other needed services. I'm gonna jump down a little bit. Non-medical case management services include all types of case management encounters, face-to-face, telehealth, phone contact, blah, blah, blah. Then it goes on to say initial assessment of service needs, development of a comprehensive individual care plan, timely and coordinated access to medically appropriate levels of health and support services, continuity of care, client-specific advocacy, continuous client monitoring to assess efficacy of the plan. So again, relevant to that, in order to do appropriate non-medical case management, you are doing an initial assessment, which includes the assessment of their follow through and or needs and or barriers as it relates to medical care. Then you're coming up with a plan of action to address those barriers to medical care and other issues. And then you're monitoring, meaning you are looking at the outcomes of those activities under non-medical case management as it relates to non-medical care. So I'm not getting your premise as a starting point. It doesn't make sense to me because that's not what this document is saying.
All right, let me pull that up. And so let me point out that it says in gaining access to, not tracking the medical. So if you read through the medical case management, you'll see that terminology changes drastically, right? And the part of the medical case management, and I'm probably ad-libbing, but so let me pull it up, is the tracking of medical indicators, right? So if you read the National Monitoring Standard, any type of medical tracking and non-medical case management is not an allowable expense. And so that's not something that non-medical case managers should be tracking at all. You can say, hey,
that's not what this says though. It specifically says continuous client monitoring. So that is tracking. That's what it says. Monitoring is tracking to assess the efficacy, i.e. the outcome, the impact, whether or not it's effective or not. That's what it's saying.
I hear you there. So let me go ahead and pull up non-medical case management. There we go. All right. So, sorry, I'm working on one screen today. I'm not used to that. Let's see. That's it right there. All righty. So this is the National Monitoring Standard, which was recently released in 2022 at the end of the year. So when we look at the performance measure and methodology, the scope of activities include guidance and assistance to clients obtaining medical, social, and those things that you had mentioned earlier. They're also interested in non-medical case managers and doing benefits and entitlement counseling, and referral services are provided. Services of all types are covered, so face-to-face or telehealth. Where transitional case management for justice-involved persons is provided. So this is also sometimes that you can fund that in certain jails, or release programs. So the subrecipient responsibility is to maintain client records that, again, date and encounter types and whatever key activities were included. So let me just bring this again. So the assistance to clients obtaining these services. And now let's look at medical case management so we can see the differentiation and definitions. No, let's do it again. Oh, come on. Case, medical case. So medical case management, the documentation the subrecipients provide, either medically or credentialed, documentation that the following activities are being carried out for clients are necessary. Initial assessment, notice that this is a lot different than what non-medical says. Development of a comprehensive individualized care plan, coordination of services, not assistance in accessing, the coordination of the service to implement the plan, continuous client monitoring, and the reevaluation at least every 6 months. Also here, documentation in the client records. This is very specific in case management, which is not listed in non-medical. Client-centered services that link the client to healthcare, social, psychosocial, coordination of follow-up of medical appointments and treatments. That's not in non-medical. Ongoing assessment of clients and other key family members' needs, treatment adherence, not in non-medical, and client-specific advocacy. And so here, when we look at the subrecipient responsibility, again, this is the administrative section of that, which is provide written assurances to maintain showing medical case management services are provided by a trained professional, medically credentialed, or maintain client records that include required elements of compliance with programmatic to include those specific activities. So we do see that the case management section requires the specific tracking of medical outcomes, where non-medical case management does not. Again, non-medical is a support service, not a core. They should not be tracking. They should not be tracking or looking for continuity of services in medical care, simply because it's a support service.
So can you also pull up PCN 1602 non-medical case management services?
Yep, and we'll look at both of those as well. No, don't do anything. Stop. Get rid of it. There we go. Can you see that? See, let me find. Is it hyphenated, Jerry? It is. There it is. So key activities for non-medical. So again, the provision of a range of client-centered activities that focus on improving access, not establishing access, and retention in the needed core and support services. So what it's saying is that making sure that clients have that referral to the services they need after they complete that initial assessment, right? Provides coordination and guidance of assistance in medical care. Coordination, again, is the key there, making sure they're getting linked to care or linked to the services they need. Assisting clients to obtain access, right? Nowhere here do you see that they say track any of the medical outcomes.
I'm sorry, I was asking that we take a look at the PCN, not the National Monitoring Standard.
This is PCN 1602 right here.
What you have on the screen is the national monitoring standards.
Oh, am I not sharing? Okay, my fault. Sorry.
I'm looking right at the standards. Yeah, you're not sharing the PCN.
Okay, my fault. I shared the wrong screen. How about now?
Yes, that's it.
Yep. And that's what I was just reading from. So the provision of range of clients, improving access, focused on improving access is the key there. Nothing here says anything about tracking medical outcomes. Non-medical case management is to make sure you get referrals to the services you need.
On that last bullet, it says continuous client monitoring. So that is tracking. When you're monitoring something, it is tracking.
Right, Jerry, but up above there in the definition, it says focused on improving access to. So that's saying, like, I'm doing an assessment, you need a bus pass, you need to go over and see legal, you need to go and get an oral health referral, right? Nowhere in this definition, and we're going to jump down to medical case management in a second to see the difference here. Non-medical doesn't say anything about tracking medical outcomes. When it says continuous client monitoring, it's because when you develop the plan, you identify the client needs a referral to HOPWA, the client needs a referral to oral health, and the client needs a referral to legal. So you're tracking to make sure those happen, right? Case management does the exact same thing, except for it adds the medical component. So let's look at medical case management. And if you notice behind the name of medical case management and treatment adherence, nowhere did you see in non-medical case management the tracking of treatment adherence. So here, the activities for this service include, making sure that you're working with an interdisciplinary team, making sure you're working with their medical team to develop the comprehensive plan, making sure timely and coordinated access to medically appropriate levels of health and support services. So again, I feel like this one takes it to a different level of specifically identifying medically appropriate services, right? Reevaluation of the care plan, ongoing assessment of family and key members in your personal support systems, treatment adherence counseling, which is not listed in non-medical case management. So again, from what I've been told from HRSA and their guidance, those medical activities should not be done, is not an allowable expense, and should not be done in non-medical case management.
Okay, so
Again,
know that you and I are in disagreement, and that's okay. Because again, when we read things, there are always subject to interpretation. And so again, when I see under non-medical case management and it says timely and coordinate access to medically appropriate levels of healthcare, like it says in medical case management, they're more similar than they are different. And again, when I look at monitoring, for me, monitoring means not only looking at the access, but looking at, when it says efficacy, looking at the effectiveness of it, which is an outcome. So that's how I read that. So I just differ from you in that way.
yes, sir, I agree. And I totally hear what you're saying and not take that away from you, sir. The only other thing I would point out there is that non-medical is a support service, which means it doesn't necessarily directly lend itself to doing medical things, where medical case management with treatment adherence is considered a core service, which has more medical outcomes. While they all have some type of medical outcome, that would be the differentiation again for me. And so we will continue to work on that with this work group and seeing how we can, make a better system.
Join the meeting.
All right, can y'all see the PowerPoint again?
Yes,
Are you seeing agenda or which one are you seeing?
agenda.
Okay, thank you. I went back too far.
Jesse. Join the meeting.
All right. So when we talk about the vision of the tier system, will kind of work like this. Level 1, which would be kind of a low acuity, which the direction we're going would be non-medical case management per se, would be client contact at least once every 6 months. These are our low need clients who may need the occasional check-in, bus pass, oral health, transportation, legal. referral for healthcare or something like that, right? Or, a co-payment or something of that nature. Reassess the acuity in the care plan at least once every 6 months. Our moderate, and again, this will be all based on the acuity score. Our moderate case management, at least contact once every 3 months, means documented contact. And that doesn't mean, hey, Thomas, you got a medical appointment, just reminding you, have a good day. That's not medical case management. That's not medical case management on any level, right? That's a part of it. But if that's the only contact that you've had with a client in 4 months, you're not doing that client any justice in medical case management. And that's why we want to kind of, parch out the tier levels. That's okay for level 1, not okay for level 2, which would be contact again once every 3 months. And in that, there's a couple of things that we definitely want to check on in accordance with that. And we'll look at those components in a second. And then level 3 would be intensive case management, meaning that you're going to have contact with that client every month, and at least reassess the acuity and care plan every 3 months. Again, there are some specific requirements for clients who enrolled under specific categories. Someone who is newly diagnosed requires intensive case management for at least 1 6-month period. Someone who's returned to care, 6-month period. New to care, 6-month period. Someone who's pregnant, recently released from incarceration, someone in substance use treatment, or has significant comorbidities, right? Because those will all work themselves out in the acuity system anyways. So the clients, the acuity score will be used to kind of total the client's assessment and the coordination listed above, raising the acuity due to certain circumstances or assign the client to a specific level, level 1, 2, or 3. So what are the components of case management? There would be an acuity scale that would be utilized to determine the level of case management required. Again, this should be completed in accordance with the chart here, how often. So for levels 1 and 2, every 6 months. For level 3, intensive case management, once every 3 months, because they have high needs. We want to make sure those needs are being addressed. The needs assessment, the care plan. Care plans should identify client service needs, goals, objectives, and desired outcomes, action steps for completing those, and a realistic time frame for meeting those clients' goals. Referrals to ensure clients are receiving those referrals for services identified in the assessment and acuity. So many times when during the monitoring process, Millie and I would review those acuity and needs assessment reports or the CARS reports and notice that someone had been identified as needing housing. And guess what? We never saw in the file any type of housing referral, or someone who needed, medical nutritional therapy or some kind of food bank or assistance in that nature, and then just the lack of referrals for those, or finding out what happened to that referral. And so that's something that we want to make sure that we're closing that gap and closing that loop, and that someone was referred. And in fact, as a case manager, you verified that client went to that service. Looking at reassessments and outcomes, the expectation that case managers are ultimately responsible for verifying that a client is receiving the expected services that are necessary to meet the client's needs identified in the needs assessment and acuity score. Monitoring the client's progress and completing the goals identified in the care plan, and making sure that that's documented in the client's case file. Documentation of the review and revised care plan needs to be updated at least every 6 months for levels 1 and 2, and once every 3 months for level 3. Making sure that we also have case notes and client contact information, so you're able, if something happens to one of your case managers and someone else has to step in, let's say your case manager is off on vacation for a week and Thomas has to step in to look at your case notes, they're succinct, and I understand what's happened with the client at the last, and I know how to make contact with the client if there's an emergency. So just some basic premises of how case management should be completed. And again, there will be kind of a case management series of trainings throughout the next year to address these areas. So what we would like to suggest that we do is create a case management work group, and which will consist of recipient staff, collaborative research staff, subrecipients, planning council members, consumers, and I forgot to add a key component to this, which would be our health information system partners at RDE and eCompass. because these changes will also need to start being documented in that system as well. And so we will be sending out an email asking those of you who are interested in joining this case management work group and getting all of the logistics worked out, that you please respond and let us know that you are interested. So we look at timeline and implementation. Again, introduction happening February of 2023. Work group meetings between February and July. It may be necessary for us to extend those as well. So these again are all changeable or interchangeable and movable, except for the official kickoff date of March 2024. With the acuity scale initiation in July, subrecipient coaching and training starting then, and how to start ramping up, and providing technical assistance at that time to be ready to be successful in the case management model. Any questions or discussions? All right. Next, I will kick it off.
No, I'm
Oh,
here.
sorry.
I'm here.
Oh, yes.
No.
Sorry.
My question is this acuity scoring on 3 tiers. What is it really going to affect of what we're doing at our present?
It's going to increase medical documentation in our system.
Okay.
That's our main goal, is to make sure we got documentation and that our clients, we can verify that our clients are linked and retained in care. Too often, as we did the monitoring process and a lot of non-medical case management agencies, we see the simple one-off of, oh, Thomas needed an oral health referral, got you over to the dentist, but guess what? They never asked. Are you going to your doctor? Are you virally suppressed? Like little things, right? That aren't happening. And so that's the whole idea of rolling it all into case management so that we can ensure that it's happening. Now you have the obligation of asking those questions and making sure that linkage and retention and viral suppression is taking place.
Now, will this be done via E2, or will it need to be done hard copy in the client's file?
I'm gonna let Millie answer that, but I think she's leaning towards everything needs to be documented in the eCompass system.
Okay, and you know that we've had problems, or no, not problems, excuse me, situations with documenting and correlating clients' medical visits in E2. Will that be fixed?
So I'm gonna hold your horses for a second. I think our
Okay.
team has a presentation.
Okay.
You're still in the thunder, Tisa. You're still in the thunder.
I'm sorry, it's
No,
my
you're
medication.
I'm messing with you.
I have two, I'll say 2 concerns besides what I already mentioned.
Go ahead.
My first concern is from my, I'll say, administrative hat. And relevant to that, when we're looking at, I'll say, transitioning everyone away from non-medical case management into medical case management, it talks about training. It talks about medical credentialed and training. This Bergen-Passaic TGA has not offered regular training, 1. 2, training, relevant to true medical case management. It is being offered in Newark EMA. Within the Newark EMA, they are not eliminating non-medical case management. When it comes to the Newark EMA, they are not looking at non-medical case management and interpreting it in the same fashion as you are. And so, again, I just question whether or not, 1, it's a valid interpretation if one of the leads in New Jersey are not doing that. They're not seeing through the same lens that you're seeing. I'm not saying your lens is wrong, but know that that lens is not the view of what's happening in one of the leads in New Jersey. And so I have concerns about that. Looking at the educational and the credentialing and the training, that support has not been here in this area. I send my staff to Newark to get training on case management. So how are we going to rectify that piece? That's one, that's the administrative hat. Do you want to hear my other hat first, or you want to take that one in?
Let's do that one first.
Okay.
And so Millie and I are working on a plan, like I said earlier, that we would start rolling out kind of the case management educational series throughout the next year and ramping everybody up and making sure they're trained. As far as the medically credentialed piece, we have already posed that to HRSA as a question of guidance. I'm a little confused by that because in that essence, medical case management not co-located with a medical facility is no longer eligible for medical case management. So if you're not medically credentialed, meaning that you have a license, like an LPN, RN, nurse practitioner, some type of medical license, you shouldn't be providing case management. It's how I initially read it. And, you know, if we take it for what it's written for, I mean, HRSA still has not answered. We've been asking that since that standard came out. And that was like a huge thing that stuck out to everybody. And what we've been told by project officers is to keep on providing services to continue that. All right. As far as, again, the case management training, as we identify needs and technical assistance needs, again, we do rely highly on you, not you specifically, Jerry, but subrecipients to let the recipient know that specific trainings are needed. So we, you know, we're going to do the baseline trainings of how to be successful at case management. And then if there are additional needs, please, again, let your recipient know that there are needs. And then there was a second part of that, Jerry. I forgot what your other question was.
Well, I was just talking about, I'll say your interpretation and your angle that is not shared in Newark.
So, and I'm going to throw this out and.
Let me just say something,
Oh, go ahead.
Jerry, we'll look into that because our PO is the same PO in Newark. So I'll just get further clarification on that going forward.
And I will also throw in there that during the monitoring process, I will say what confused me the most is that organizations who are co-funded for both non-medical and medical, you made a differentiation that your non-medical was not able to do certain things. And so in the same day, you would not you, Jerry, specifically, I'm just saying in general where we saw, people would pass a person through non-medical and then on to medical and spend 6 hours time-wise. So I'm confused by, so to help alleviate that process, one person can do it all. Because what was happening is we were told the non-medical case manager couldn't do the medical things. So they passed them on to the medical case manager who did the exact same thing that the person just spent 3 hours with them in non-medical case management did. And so that's kind of to help alleviate that, what I call double dipping, because you essentially did not spend 6 hours with that client. And so that's what we're trying to do. We're trying to streamline the process so that medical case management looks the exact same across the entire jurisdiction, right? And if we're not able to say, oh, well, Thomas needed a bus pass, so I sent him to non-medical case management. Well, guess what? The medical case manager can do that exact same thing. And so that's kind of the approach that Millie and I had been discussing. And again, we will get clarification from the PM, the project officer.
Okay, so now I'm putting on my planning council hat now.
Alrighty.
For two reasons. So interestingly enough, one of the directives coming down the line for the office of the recipient would be that there would be notification about challenges, problems, issues, whatever you want to call it, regarding your service category prior to looking to change it, alleviate it, delete it, eliminate it, whatever you want to call this. And so again, I have an issue if there's something that has been identified, again, planning council hat, something that has been identified as an issue, and the planning council is not aware that the service, if you will, is not being delivered the way it's supposed to be delivered, or blah, 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 whatever we do relevant to outcomes and all that whole thing. So I have an issue with that. The other part of that question or concern is, you know, speaking back as a provider, again, is if there's something that's happening and providers are not doing it accurately, appropriately, the way it's supposed to be done, there should be training guidance to alleviate the problem versus saying, oh, we're not doing it right, so we're going to eliminate it. That's not appropriate management of these programs. That's my belief, and I'm not debating that. That's not okay. The other part of my planning council hat which is a greater concern, is allocation of dollars. So here we are, we just eliminated a support service called outreach. We took those dollars from outreach, we put them into EIS. Now, the same thing is coming up relevant to non-medical case management, which is a pretty large funded support service category. We're now looking to put that support service dollar, I guess, I'm not sure what that's going to look like, but again, we're talking about eliminating that support service dollar for that service. And now we're looking at increasing or potentially increasing the assigned dollar to a clinical or core service, meaning medical case management. Let me say that one more again. And so here we are. Historically, we run at 75% clinical core services, 25% support services. And where is this money coming from, relevant to the other clinical service? Where is this money coming from to support now everyone's doing medical case management? And so as a planning council person that participates in priority setting, I have a concern about that. I don't know if anyone else has a concern, but I have a concern about that because you're looking at a chunk of money to support the service now that may or may not be there. And
Right.
so,
Yeah, I think, isn't this a planning council decision, what category to fund or not fund?
So it is kind of twofold, right? So I don't want to say it's not valid because the service technically is not going away. Non-medical case management would move into medical case management, and that service is still being provided at a more efficient level. So the services that are taking place in non-medical case management are not going away, just like with an outreach and EIS. Outreach didn't go away. You can still use outreach and EIS. The differentiation is that outreach people who were not HIV positive were being provided services. Nobody had a plan for how they were conducting their outreach. Nobody had targeted plans of how they were reaching out to specific populations of high need. Nobody had testing plans. Nobody had prevention plans, right? So that same service wasn't done away with. It was moved into EIS, who can provide the exact same service. Same thing with non-medical case management. That service isn't going away. It's being provided under medical case management. And to speak kind of to the 75-25 split, the minimum threshold for core services is 75%. So if that number goes up, we're in a lot better shape. And Millie can attest to this. We have been teetering on that 75.32% before having to file a waiver to ask the government, can we spend more money in support services, right? The more money we spend in core services is better because the core service is the main goal of the Ryan White program, right? While 25% can be core to help with support services, the main goal is for there to be more services in the core function. And so with that moving into core services, the money isn't coming out of nowhere. It's going to remain the same and be moved into case management services and increase core services across the TGA. And then to also speak to that coming to the Planning Council. So I know we've had kind of talks very briefly about that. Millie has not made the formal presentation of, outcomes from monitoring. And I think that was on her slate for April. We still are trying to finalize the monitoring reports. We had some people super late on getting things to us and, reviewing everything. But once those monitoring reports are finalized, then Millie can come with a better aggregate data to the Planning Council to say, this isn't happening in this service category, this isn't happening in this service category, et cetera.
right. And so that's kind of the issue, though, is the cart being put before the horse. On the recipient side, if you will, they're making a decision that has not been supported by the Planning Council. probably needs to work in the reverse. The planning council first makes a decision about priorities and funding based on needs assessment. Then that information goes to the recipient that then funds those service categories. It sounds like it's happening in the reverse, which I think is inappropriate.
And Jerry, I hear you, but let me just say that the Planning Council has the obligation to identify services needed in the TGA to best address people living with HIV. Non-medical case management and case management are very similar. Non-medical case management services are not going away. Those services are still provided in case management, right? So I could understand the premise if something was going away, like Millie's going to do away with oral health care, but that's not what's happening. The service isn't being cut. The service isn't going away. The service is still being provided. There's no staff changing, right? Those people will still be trained into delivering case management services, whether, that be non-medical or medical, it's going to roll into one. Services are still being provided. There are no services going away. But I do hear you. That is something that, we do need to bring to the Planning Council.
Yeah, I was just going to say, as I'm hearing it and soaking it all in, I was just, concerned in regards to it being, is that the main idea here? Because we're talking about, I get what you're saying, how it's clear that both categories are technically merging into one. We're not technically losing anything, but I think Jerry's concept is that procedurally, there may have been a misstep in regards to moving forward with this without it being, I guess, really thought out and going through the proper processes for it to happen in that manner. I know why we're doing it, and I definitely, we've had some conversation, and I get the value of it, but I just want to, I'm just hearing it and soaking it in, trying to understand if the proper process was followed, just to make sure that moving forward, we are where we need to be, because it definitely sounds like a benefit moving forward. But once again, I'm just hearing it and trying to understand it and just making sure we're addressing it properly.
I agree. I still think that the reasoning, but I still believe that services legislatively by the Planning Council. Presentation to the Planning Council, and the Planning Council could I agree with Jerry in the sense that, this is just coming to and I
Karen,
think
you're blinking out.
I know.
Okay.
Minutes ago, I was out for like 5 minutes. Not talking much, but I'm agreeing very much. Jerry is saying we've put the cart before the horse. The Planning Council information and should be allowed legislative requirement that they determine service category. You guys seem to have, well, you do, you have information that we've not.
Right, but keep in mind that the way services are contracted is not the purview of the Planning Council. So what the Planning Council identifies as services that are needed in the area, right? And so with those aligning with what medical case management and non-medical case management does, that can be provided in medical case management. And so Millie, at the end of the day, Millie and the recipient and the CEO have that final say-so of how that service can be provided. You identified that case management needs to be provided, and that can be done successfully under medical case management. But I do agree that it does need to come to the Planning Council.
And it will come to the Planning Council because this is something that we're not putting out there for 2023. This is something that we're looking to see. This is why we want to put a group together. This is so we could talk about this before it is done for 2024.
I thought you were telling us that this is what's going to happen in 2023.
No, not the case. No, that is not happening until 2024. If everything looks good, if we come to an agreement, the goal is for the clients not to miss any of the services we're providing. And if I could provide planning council with that information that says, look, this is the way it's gonna be, this is what we're looking for, and planning council agrees, well, hey, great. But at the end of the day, I have to make sure that I feel comfortable that this is the way it's gonna be done, that no client, no consumer, no patient is gonna miss out on anything.
So I'll just jump in really quick and say I definitely appreciate,
fine.
because it sounds like that you guys have heard the feedback, because when we talk about the process of, you know, outreach going into EIS, and I see the parallel here, and there were some concerns brought up at that time. I do want to applaud you guys for hearing the feedback and utilizing this process to actually give us the opportunity to understand it. I do see Jerry's his stance as well, and it's not just his stance. I agree that you know, realistically, if we, you know, it's better to make a decision after the information. It sounds a little different, but I do see what you guys are doing, and I do applaud you for taking that feedback from the EIS outreach process and implementing it here.
Right.
And so after this meeting, we will send out an email to this entire group asking those of you who would be interested in joining the work group. And then we will also be coming to Planning Council next month to say the same thing. Was anybody interested in joining the work group as we work through developing this case management system? Again, we want everybody at the table and we want everybody to agree, this is how we're going to do case management. So if I move organizations, that nobody's being left behind, nobody's, you know, falling through the cracks. All the services are provided at parity across the entire TGA. Great discussions, and I appreciate that. I mean, that's what makes a well-oiled machine, is everybody, you know, expressing their opinions and how they feel, and that helps, you know, both the recipient and myself make better decisions and better, you know, be better informed to the group as well as Planning Council. All right. With no further ado, sorry, Elise and Robert, and I think I saw Jesse come in and the team. We will turn it over to you. You have the floor.
Thanks, Thomas.
You're welcome.
Oh, there we go. Thomas, can you hear me?
Oh, there you are, Jesse. Yes, welcome.
All right, great. Let's see if I can. Hello, everybody. I'm continually pretending I'm in Puerto Rico, especially in February here. Let me see if I can share my screen. Try to go to slideshow mode. Do I have to switch my screen, or does that look okay to everybody? Is it full screen?
Looks good to me.
All right, all right. All right. Thank you. Thank you for all your hard work. This has been a pretty rough couple of years with COVID. Monkeypox, the world just keeps getting tougher. So I really want to thank everybody for your service, to the people we all serve at the end of the day. It's not easy work, but it's worth it. So thank you all from everybody here at RDE. For anybody who doesn't know, I'm Jesse Thomas. I think I've served RDE for almost 27 years. And Bergen Passaic, probably 18 or 19 years. I miss seeing everybody in person. Those were some fun days. I see some of the older, you know, I don't mean it in age-wise, but some of the folks from the older days. And today, I think what we're going to do is try to open up this idea of visioning. It's been a long time since we were able to step back and say, what would we love to have? What's possible? What's out there? So this is a journey. It's not an overnight thing, but we've been doing some really cool visioning methodologies, a little bit of road mapping, and we want to elicit the evolving program and user needs. You know, I understand It sounds like from the little bit that I heard, the program itself is evolving, and so those needs are changing. And there's some unmet needs. I think there's some really good opportunities to upgrade some things and be inspired by some of the innovative models from across the country. So we're going to do some cross-pollination. You'll get to see some reference models, we call them, some models from around the country. And this is just the beginning. We're going to start a little process where we want to sort of get folks who are interested to participate in some kind of ongoing engagement. And we want to look at everything through the lens of process improvement. To me, systems support processes, and the most important part of processes are people. So we got to look at all those components together. So a little bit of an outline of today is where have we come from, where are we now, and where do we want to go? Now, I had some fun with this. Unfortunately, I just had a couple of unexpected losses in my family about 2 weeks ago. And so I've been going down memory lane a little bit. And for Bergen Passaic, I have fond memories. This all started way back when I was asked to help put something online, needs assessments and client satisfactions. And this was before smartphones, before lots of stuff. And I said, I don't know about that. Let's have is there like a voices committee or like a consumer committee? And the director at the time said, yes, there is. So I got to meet with folks and I asked them, I said, hey, if we start putting some stuff online, using a computer, does anybody have access? And back then, this was like 18 years ago, it was, yeah, we've got access, we do. And I said, all right, that's awesome. And one gentleman said, actually, I've never used a computer before, but I'd love to learn how. So I got a meeting with the president of Passaic County Community College, explained the situation, asked him if we could use his computer labs and advertise for anybody who doesn't have access, can they use the community lab? And I was a bit worried what he might say, HIV positive folks or whatever. And he said, absolutely, it's a community lab. And I'll do you one better, Jess. If they've never used a computer before, I'll give them a 1-hour free computer and internet lesson. So it was really, really cool. We had some great success with that. And we did visual analytics at that time. So all the agencies and the CQN and Planning Council could see real time a pulse on the community's needs and satisfaction. And there were some really interesting things that happened. And then it kind of led to a grassroots. The providers were saying, why do we have to use our current legacy system? I won't name it. Can't we just use eCompass? And we said, yeah, let's figure that out. And I remember doing one-on-one interviews with just about everybody back then to sort of live a day in the shoes and try to capture what the needs were. And we built something, and that was eCompass. And then we started to kind of move into something called PTAS. PTAS, I'll just share, I went down memory lane. I want to share that briefly for anybody who doesn't remember that. And then we got into some SPINS grants. These were federal grants, and the first one was organic. Someone on the Planning Council from the state said, what you guys are doing in Bergen Passaic is really innovative, and there's this new funding opportunity. You guys should try. And little old Paterson tried and competed against states and large cities and won. And so that was our experience into SPINS, which the idea was great. The idea is evaluate what you're doing as you go along, learn from it, be pioneering, and then disseminate, be able to see, is this worthwhile? Share those lessons learned. Then that led to just a great process of learning from others and seeing what works, learning from experience. And there were other initiatives, I'll share a little bit, but there were some really neat ones that were done. And check this out. Can you tell this is an old picture? Look at the size of that monitor. So these were the access points that were put out. We tried to have a human touch and explain to the clients how to go about doing some of this. And this was Paterson, people taking action, saving lives. And this has been replicated in Baltimore and other places. We open sourced it. Anybody who wants this model. And it was a citywide testing, outreach, and care initiative where people at the time were falling through the cracks. People were getting information outreach, not getting tested. If they got their results, they weren't making it into care. So we tried to create a non-traditional partners approach with prevention and care and treatment and faith-based and other partners to kind of fill in the cracks. There was health literacy messaging where we had a conversation built, the true or false quiz on the top right. But we also put that into the system. And we could see community by community, what did people think? And it turned out, we were surprised, in Paterson, over 26% of folks didn't know HIV was treatable. And we said, maybe they don't want to get tested if they think there's no treatment. So that led to a big public awareness education campaign where we put HIV is treatable all over everything. We had these little tear-offs at, salons, hair salons, businesses, bars. We had a faith-based set. We had different committees for different priority populations. This one is wisdom is the application of knowledge, learn the facts about the body. Physical health is just as important as spiritual health. Your body is your temple. Get tested. It's private and quick with places to go. So we had different cards in different languages. We also pre-printed a code number on these cards with tiered incentives, so that if you got your test back then, if you picked up your results before the rapid test, then getting into care. And we also put this information back out to the outreach worker teams. These are all the folks that we engaged. How many got tested? How many tested positive? How many made it into care? How many made it onto meds? And this was before the care cascade. We gave those tools in the hands of end users in real time. Show me all the male Hispanics between 25 and 44. How's our events doing? It was really beautifully branded. Again, nice stroll down memory lane. And we looked at the data. The red lines in this report was how many engagements were there, and the greens were how many got converted to get a test. And we said, oh, look at this. And we said, what the heck, MJ? This is MJ on the right. This is at a Puerto Rican Day parade, one of my favorite stories. She ran out of incentives, didn't speak Spanish, yet everybody she talked to got tested. So the data was revealing something interesting. We said, MJ, what did you do? And she goes, well, I engaged the beautiful young Latina queen of the parade. I told her about PTAS and knowing your status and how important. She was sold. She walked around with me everywhere, and everybody we talked to together got tested. So that was showing how data and positive reinforcement, using the data for positive reinforcement, sharing best practices, and it made a difference. There was a 26% improvement of new folks into care. And so for those who don't know some of the history, there's a lot of history behind the system. And as things have evolved, we've been involved as you've all been in ending the HIV epidemic. You know the 4 pillars. I'm curious if this resonates with you. I said, I think it's missing a pillar. I think we need to reduce administrative burdens. Time is our one finite, non-renewable resource. We want to reduce staff stress, burnout, and turnover. How can we end the HIV epidemic if we don't reduce administrative burdens? And I even reached out to HHS at the time to say, is it okay if I added a pillar? I didn't see this in your national strategy. And they said, yeah, just add it. Another ingredient, when we look at this going forward, is security and privacy. Good news is you've got the tops in security and privacy. We don't have access to your client level identifying information. That's not the norm in the industry. It's way above HIPAA. So feel good about that. Another key thing is looking at things by funding source. Unfortunately, providers are often saddled with program silos and data silos. So that's just sort of the nature of multiply funded programs. So looking at that and also learning from experience from across the country. We've had about 95 publications disseminated. And what's nice about that is every time you're asked to present something, you really learn from that process and learn from others. One of the ingredients I think in that is a people first approach. So, IT projects sort of have their own kind of approach with things. We believe in more of a people first approach. And I think that can go a long way with bridging that divide between HIV program folks and technical folks. The HRSA TA group, the DISC, asked us to do a presentation on that. They were aware of our work in that. There's some really neat work. There's some really neat stuff here. And if anybody wants to geek out on wellness, we have a people and culture program here at RDE, and we're really interested in sort of wellness tools for us, for others, things like deep work and gratitude and hooky days, all kinds of stuff. But there's some neat things here if anybody wants to geek out. And another more recent story coming up to last month, HRSA had seen one of our presentations that Millie and other partners presented at the Ryan White Conference, and this was on the SPINS Housing and Employment Project. And I was contacted by the Housing and Homelessness Work Group at HRSA to do a redo of this. And this was last month at their Housing Month. This is looking at innovation in housing. So Paterson, Bergen Passaic, you guys got some top level exposure. There was about 75 folks there. Laura Cheever introduced me, and they loved the work that you all had done on this. So I think I saw TISA on there. I think there might be some SPINS partners on there. I want to give a shout out to you guys. And for those who don't know, this was a complicated project. There were multiple components, more non-traditional partners. Millie had to really engage folks across the spectrum. We kind of pulled this together, and it's beautiful human stories. I mean, at the end of the day, all this technology, all the reporting, people are not numbers. And these are the things that kind of drive us. This is what makes us want to work nights and weekends, is seeing that, you know, we had someone here who was really struggling. Capco came in, TISA came in, and this client felt really comfortable, thought it was a blessing, and she became stably housed, found success at work, loved what she did, remained undetectable. And I'm not going to go through all the details, but you know, over 12 people were housed. And this was like on top of everything else that everybody's doing. So just a great job, and celebrating the hard work that's been done and the results. Also, for those who don't know, and I've been asked to kind of put this out there, there is a new funding opportunity. It's $750,000 over 3 years, housing related, replicating some models for LGBT, justice involved, and youth. Now, can we do a little interactive poll? What I'm going to ask you to do is pull up your phone and QR code snap this, or go to e2polls.com and put in Paterson. If you just give me a second here, I'm going to pull up the live E2 polls. There it is. All right. So anybody who's got a QR reader, just point your camera at it. And click the link. And then if you have an issue with that, you can just go to e2polls.com. It's always on the top left. And the code is Paterson. I see we got 11 people joined. Got 13. How many people are on the meeting itself? Give folks another minute.
39.
Just a little interactive engagement. 39. Ooh, only 15. Okay. Give folks another minute. If you have any issues, just put something in the chat. Pasiana, Robert, other folks are here. And while we're waiting, big thanks to Robert and everybody on the RDE team. Thanks to all of you. Thanks to the recipient. Thanks to everybody involved in this. It's exciting to kind of plan the future. All right, well, I'm going to get going. You can always join. Okay, it'll always be on the top left here, e2polls.com. Code is Paterson. And if you look at your device, you'll be able to participate.
Jesse, could you put the scanner up just one more time?
Well, Tisa, if you don't mind, if you go to e2polls.com on your browser, and then just it'll ask you for the code is Paterson. Actually, maybe I can pull it back. Yeah, there it is. Got it? All right. Cool. All right, so we've got other. If you put other, just put it in the chat if you want. I'm curious who we're missing here. Should have better categories. Case management planning. Great, great. Now, here's an interesting one. How many years have you used eCompass? 1 to 5, 6 to 10. Cool. Good mix. have you participated in any of the SPINS projects? Anything like innovative demonstration projects? We had a housing and employment, a health information technology, electronic networks of care. All right, good mix. Two more people typing. All right. Okay, I'm going to leave this slide up. You can just put any comments, thoughts, questions. You see something you like that we're going to show you in a minute. I think, you know, put some love in there. That's always welcome. So where are we now? Let's both celebrate and continually improve. We asked, you know, some of you may know we call you once a year. We've been doing that for a long time. We ask you about, you know, how do you feel about the system, the reporting, and the help desk and support? But the more important thing is, if it's not a 10, what can we do to make it a 10? That gets fed back to the recipient and Thomas and team, and that helps evolve the vision over time as resources and time are available, of course. But as a joint team, all of us together, these are great numbers for a government mandated data system, and we want to celebrate that. We get lots of love. We really appreciate it. It really helps the team, you know, work hard, and just some of the beautiful comments. Thank you, thank you, thank you. And we also have feedback. We know that automated eligibility is something that we would love to do. We'd love to have document uploading so everything's all together with eligibility right there electronically. And we know there's some enhanced reporting features that are desired. So as we go into, you know, building a dream system over years, but what's the first version of that next level? Again, trying to look at this holistically integrated, right? What are the systems that need to change? The people, the workflow, the processes, how can we be supportive for everybody? And then, you know, as leaders, as visionaries, work backwards. What are the bottom line impacts? What's kind of return on investment? What kind of outcomes do these different modules or pieces lead to? Is this time savings? Is this data quality? Is this reducing staff stress? Is this improving planning? CQI, population health? Is this going to help serve clients better? Is this going to help with grants? Tell your story and get more grant funding? Is this going to help make compliance easier? Is this going to support practice and program transformation? So there's lots of different things here by different stakeholder perspectives, right? Each stakeholder has their own unique and important perspective. So we're going to show you some things Robert's going to walk you through. As you look at them, think about replication. Is this something immediately replicable? Or is this something that's similar that can be adapted? Or do you have some blue sky, some out of the box thinking? So there's different resources in the visioning that we've been doing around the country. There's a really cool innovation database that we call E2 Genie. We'll show that at the end. There's some disseminations. You could see 90-minute workshops of like how these things are done, best practices, lessons learned, overcoming obstacles. There's implementation and replication handbooks out there. We do our own geek out sessions. So like I said, I'm interested in wellness and some creative community engagement. There's other things here too, but we're going to move into the last one, which is demos. So Robert, I'll let you take it away. And thank you very much. I'll pop on a little bit later. Thanks, everyone.
All right, so I'll share my screen. All right. So for today, I'm going to be going over one of our reference models. So this is our E2 Connecticut reference model, just rebranded to our E2 Bergen per se, just to give a better picture of future. So this right now is an example of one of our client screens. So on this case, it initially shows no clients on search, but if you begin typing, it'll show up your client results. So this can be just specified to show all your clients, have even a more detailed search by first name, last name, by certain required fields to prevent phishing, or this general search field, so you can search by any of the indicators on this table to bring up any clients in this list. So just to start off, we're going to go add in a new client. So very similar to what we do currently, you add in your client information, date of birth, Let's put a little older. Any case manager information, sex at birth, gender, and you can add an intake date. You check for existing clients to see if there's any duplicates found in the system. In this case, no. We can go ahead and create our clients. One of the new things in this reference model is the ability to upload a client consent document. So a document is required to be uploaded before you can view the client record. So one of the benefits of this is not only just having a document on file of the client consent, but also for data sharing, depending on data sharing rules set during the spec development phase. The client search can have the list of all the clients in the TGA, and you can only access those that have a client consent uploaded. So if you need to access a client from another agency, you can simply search that client credentials, upload that consent document that you've entered, and then you can have access to that client record. But that's just one of the data sharing models that are available. But once you do enter that client consent document, you'll see this is now our intake information. So we have our standard intake information being collected above. So again, your first name, age, gender, all that information above. We also have a document tracker. So this is a secure document uploader. So you have the ability to upload PDFs, Word documents, or images to the system. You can specify a form type. So if we have a proof of identity, or we have a proof of residency, you can specify the type, so a water bill, mortgage, and just a general ID, set an effective date, and upload your document. So once that's uploaded, again, that's secure. So if you have your LPM blocked, you are unable to download or view that document. But if your LPM is unlocked, you can download and view those documents for future use. At the same time, if you look onto the left-hand side, we have our client sidebar. So on top, we have some just general information about the client record, your name, gender, date of birth, E2ID. But also we have included is our eligibility module. So this is our automated eligibility calculation. We can see this client is currently uneligible. And if we click on the little question mark, we can see the eligibility requirements. Right now it's displaying what fields are required to be filled in and would auto-calculate, trigger an auto-calculation for the eligibility module. And if we want to see why this client is ineligible, we simply click on the ineligible button, and we'll see we're missing a state field, their HIV status, and we're missing a few various documents such as HIV, identity, residency verification documents. So as you go through the system and fill them out, you'll see these, each individual line item get ticked off before they become eligible. So if I go over to another record, this client is John Doe, and now I filled in all his eligibility requirements, have his documents on file, and you'll see now he's eligible for a Part B plan. He has a start date of today, and it expires 7/29 in this year. So if we check the history, you can see his eligibility start and end dates, his current FPL level, and his eligibility. So it's eligible for Part B. So for every reason, while you're making edits to the document, if he changes eligibility plans, if there's a Part A, Part B, or Part C plan, you can see those changes here and see when there's any changes in eligibility. In addition, there's an audit report. So if you do want to see when a particular document or field was changed, that would trigger an eligibility change. You can see here, see when it was modified, who modified it, and what particular field and value was modified. Moving on, we have our standard demographics field. To enter demographics information, same with HIV and HNI, or housing and income information. One additional benefit here is housing, insurance, and income information is tracked as a grid, so you can see, have an easier view on the historic records for their income, for example. So you can see for 2023, his FPL level was 218. But if you go further back in time, you'll be able to view at a glance his historic change of income, housing status, or health insurance, which again is useful for various reporting needs such as RSR reporting or HAB reports. You can just have a glance instead of going into the history of the field. Moving on, we have our medical. So this is our labs, annual review, immunizations, medications can be entered here. Going into labs, you can enter lab dates, specify specific lab type. So if I want to go into LDL, for example, I can enter a lab result, equals, greater than, less than, greater than, equals, and enter a number as its specified counter and save it for day 2. And now I have that record stored here, so it can be entered for various lab types. Similar with annual review, I can enter a substance review state and his screening round results. So it was yes, screened, not medically indicated. And also moving forward with immunizations and medications, similar with data entry rules. So you can select your immunization type, the dosage received, and the immunization status as well. For referrals, it works similar to your current system, but one of the benefits of the newer model, so we can select our referred by. I'm referring to buddies, for example, for referral dates of today, a service category of early interventions, yeah, yes. You have a C validation that this receiving entity doesn't have access to the client, so they'll need to access the consent letter to access it. So I say I can have that consent document uploaded so they can have access to that record, so I can upload their consent document. And at the same time, when I send over this referral, I can attach any supportive documents as well. Again, this is a secure document uploader that are required for this referral. So I can attach documents to this file, and then when the receiving entity receives it, they can view those files as well for that client record. Moving on to services, this is our service entry screen. Again, similar to your current system, except just a slightly different layout. So you enter your service date, you can select your service type of whatever is contracted for your agency, enter unit amount, unit cost, and add your service. On the secondary screen, you'll have a service detail screen that can be customized just based on the particular service has been selected. You can fill in and save that information. And just viewing some reports, one of the key upgrades in reporting is our digital analytics report. So if you go for the top, you have the ability to filter by service, subservice, funding source, and service date range. You also have the ability to select individual filters. One of the benefits here, like for CD4 count and viral load, you can select those filter types. So you can say greater than or equal to 200. If you need another less than or equal to, you can also add that as well. And that'll be applied to your filtering for when you run the report. Of course, you can go through each of the indicators. Typically, any of the one-time data entry fields will be included under each section. You can add as many filters as you need, as well as select a particular section you want to view. So if it's intake information, HIV status, or demographic, or so forth, you can view that breakdown. And you can add up to 2 breakdowns of client demographics, such as race, ethnicity, and such forth as well. So when you run that report, it'll pull up a list of clients in the indicator. You have each section, you can drill down to a particular category you want to see under, in this case, client information. And you can click on the record number to view the drill down of clients in that indicator. And of course, you can view that client record if you need to make modifications or just make changes to that record. All these reports can be exported to PDF and Excel by default. So if you need for any reporting needs on your end, you can export those files as well. Last thing is our HAV report. So our HAV report has our standard data filters, so service, report date range, service subsource, and specific contract. You have your measurement date periods above, and then your performance measures listed down below. All the numbers here are drill downs. So if you click on a record, you can view your client drill downs, as well as clicking on the question mark will give you the information for the indicator of numerator, denominator, and any exclusions. But that's just a quick rundown of the E2 Connecticut model. RSR reporting is standard to what you currently have, just has updated UI, but all the features are what you currently have in the E2 system. So that's just a quick overview of the E2 Connecticut system. Jesse, you want to take over?
Sure. All right. Share my screen. Thank you, Robert. I know we don't have too much time, and that was pretty quick, but I definitely want to get your quick feedback here. If you go back to your E2 polls, and if you, it should remember where you left off, but for some reason, if you need to join again, it's e2polls.com, and the code is Paterson. What features or aspects, what you've seen today, and again, I know it was quick, but do you think this is a good model? Is this some good stuff here? The automated eligibility, the reporting side of things. And if you're not logged in, you could just stick it in the Zoom chat too. That's where it's easier for you. See 4 more people typing. If for whatever reason anybody has to pop off exactly at 2 o'clock, just put your email in the chat if you'd like to be one of the pilot testers of this. Okay, and is there anything extra? Like, is there something that, if you had a magic wand, and by the way, if we do a deeper visioning session, we can share more models if we have more time. There's a bunch of neat stuff out there. Is there anything big that you would love to see as well? All right, great. Well, this is the one I'm going to just hide my screen here, finish up with the slides, but on your device, if you put your email address in, you want to be a part of that, and making the vision real, looking at sort of that gap between where we are, where we need to be, and prioritize and get resources all set up, and there are maybe some grant opportunities. And then next steps for us as any interested users, we'd love to walk you through these reference models and then think critically, is there something missing that you need that's essential? Because again, as I said, your system has been customized over time. It doesn't have some of these newer modules, but you do have some unique things, unique to you. So we want to make sure whatever is ultimately launched will meet all the essential needs. And then we're going to be doing some ongoing engagement, design, and planning, and look forward to kind of keeping everybody up to date. We'll leave the Q&A open. How do we accomplish ambitious goals? One bite at a time. Thank you very much, and open to any questions, comments, anything. Thanks for taking a trip down memory lane with me.
Thank you, Jesse, and the RDE team. We do greatly appreciate you sharing all the great information with us. I look forward to the new reporting. That's going to be fun. I think we can do a lot of data to care projects and just being able to successfully manipulate them, indicators and things of that nature. So I'm super excited. That's going to be a lot of fun. Thank you and your team for all the hard work and preparation that people don't see on the backside of all this. Yes, it's not a couple clicks of the button. So we greatly appreciate all the hard work that you're doing to help us be better at what we do. So thank you, sir. All right.
Thank you.
Yes, sir.
Thank you.
Brought up a lot of good memories.
Yeah. All right. If there are no additional questions, we will give you back the rest of your day. So thank you for spending 2 extra minutes with us. We appreciate you. And again, we look forward to additional meetings in the very near future to talk about more. So thank you, and we hope you have a great rest of your week. All right. Bye, everyone.
Thank you.
You too.
Bye.
Good night.